everyone. We're going to go ahead and get started. So welcome to the first LEAD seminar of 2019, which is co-hosted with the Department of Epidemiology. You guys have all been hearing me talk about today's speaker for quite some time now, so it should be no surprise when I say I'm very excited to introduce Dr. Matthew Gillman. As many of you in the audience already know, Dr. Gillman is the inaugural director of the Environmental Influences on Child Health Outcomes program, also known as ECHO for short, which is a consortium of over 50,000 children in cohorts across the United States. So prior to Dr. Gillman's current position, he had a long and productive career at Harvard Medical School, where he completed his clinical training in internal medicine and pediatrics, and then continued on to start and direct many amazing things, including the obesity prevention program within the Department of Population Medicine and the Project Viva pre-birth cohort. During his time at Harvard, Dr. Gillman published widely on early origins of chronic disease. He also took on several leadership positions, including on the U.S. Preventive Task Force, and he received many mentorship awards. So I'd like for you to join me in welcoming Dr. Gillman.
Thanks a lot, Wei. It's really a pleasure to be here, partly because I missed the snow in both directions. I left D.C. just after it snowed here and just before it snowed there, so if I'd come a day later, if I'd planned to come a day later, I probably wouldn't be here. Secondly, to be introduced by Wei, who I had the pleasure of working with when she was a postdoc in Boston. Third, to see so many familiar faces and to get introduced to new people while I'm here. So thanks a lot for having me. So let's see. I'm going to try to do, there we go. So today I thought for the first part I would give you an introduction to ECHO, but then share some musings about considerations for 21st century child health research. One is something we're trying to sort of integrate into ECHO, which is solution-oriented research, creating evidence that has an impact on policies, programs, and practices. Talk to you about a novel outcome in ECHO called positive health, not merely the absence of disease. And then some, I hope, somewhat controversial and discussion-raising points about precision prevention. Why do we care about mechanisms? What's prediction versus etiology? Some cautions about big data and then tailoring interventions. And finally, what ties things together in ECHO, best practices for transdisciplinary team science. So the mission of ECHO is to enhance the health of children for generations to come. And through our guiding principles of teamwork, impact, responsibility, and value, we take the position that a good start to life can last a lifetime. And many of you here will recognize this as part of this paradigm now called developmental origins of health and disease, which posits that perturbations or cues, insults that happen at early plastic developmental periods in life can have lifetime, sometimes irreversible consequences. And so to ensure the good start that we're talking about, we need to understand potential risks and resilience factors. Maternal obesity is something that many people in this audience have an interest in, including its consequences like gestational diabetes. We're interested in things we find on our shelves and healthy and unhealthful habits. And then we need to find out when and to whom they apply so that we can do what many call precision prevention. And finally, to take action in our kids and our families through programs like clinical trials and policies and practices that will improve the health of our children and adolescents. So ECHO is a nationwide program. It consists of about 60 awards and about 110 principal investigators over 200 sites with 1,300 key personnel across 44 states, DC, and Puerto Rico. And under the umbrella of ECHO, we have two major components: our observational studies, those are the ECHO cohorts that Wei introduced, as well as our clinical trials through what's called the IDEA States Pediatric Clinical Trials Network. And these are supported by the The other 5 components you see: a coordinating center, data analysis center, CHEER, the Children's Health Exposure Analysis Resource, which measures chemicals and metabolomics, the PRO-core, Person-Reported Outcomes core, and our newest core, the Genetics core, which will be responsible for genotyping the mothers and kids in the cohorts. Just a couple slides on the Idea States Network before I spend most of my time talking about the cohorts. The Idea States Network consists of 17 clinical sites and its own data coordinating and operations center. These 17 sites are in states with historically low rates of NIH funding. And the goal of the Idea States Network is to provide access to state-of-the-art clinical trials for medically underserved and rural populations of children. And to underpin that is to build national research capacity in pediatrics to conduct the trials through professional development and infrastructure team support. Ultimately, the idea is to apply findings from relevant pediatric cohort studies, such as the ECHO cohorts, to children in the Idea States. And currently, there are 3 protocols in the field, 2 more under development, as well as some pilot studies in the pipeline. So turning to the ECHO cohorts, there are 31 cohort awards. Some of the awards have multiple cohorts under them, so there are about 70 cohorts representing 68 principal investigators. Most of the cohorts started prenatally, so there's data from pregnancy throughout the life course. There are a couple that started preconception and a few that started after birth, and they tend to be the ones that were started in NICU, so they have a preponderance of premature infants. The overall scientific goal in the cohorts is to answer solution-oriented questions about the effects of a broad range of early environmental exposures on child health and development. And by a broad range, we mean everything from society to biology. So not only physical and chemical, but also societal variables, medical, psychosocial, behavioral, and biological. Somewhat arbitrarily, ECHO defines the exposure period as conception to age 5. And then we're looking at health outcomes throughout childhood and adolescence, including these 4 with high impact on child health. So pre, peri, and postnatal conditions, upper and lower airway, obesity and its consequences, and the many facets of neurodevelopment. As I was saying before, we've added a 5th outcome called positive child health, which is, again, not the absence of disease, but focuses on assets that enable well-being, such as happiness, life satisfaction, meaning and purpose, relationships, and achievement. As well, the working group that's doing positive health has incorporated sleep duration and quality. And I'll come back to positive health a little bit later. So what's our overall main goal in the cohorts? It's to create what we're calling the ECHO-wide cohort, and that's to weave together 70 existing cohorts of mothers and children. So all of these pre-existing cohorts are following up the kids, and many are still recruiting during pregnancy. And the idea is to establish a single data platform to conduct both etiologic and prediction research, and to establish a protocol that harmonizes to the extent possible existing measures and standardizes new measures. It's interesting, you can, those of you in epidemiology who remember what inception and dynamic cohorts are, if you replace the word participant with the word cohort, putting together the ECHO-wide cohort is like putting together a dynamic cohort of inception cohorts, because they started at different time periods in calendar time. They started at different periods of the life course, and they have different visit schedules and different data collection schemes. So it's a bit of a trick that the investigators are really doing a great job doing. And so what we wind up with to do this harmonization and standardization is an ECHO-wide cohort data collection protocol with essential and recommended elements across life stages. So all the cohorts are expected to collect the essential data, and then as much as possible the recommended. So on the left you can see just a schematic of how this might work. So we have domains and concepts, and you can see the expectation of collecting them at each of different stages in the life course. Those are the X's in the table. And then on the right, many people in this audience are interested in things related to diet, physical activity, sleep, and adiposity. And here you can see some of the elements in the data collection protocol that are related to those. to those domains. And I can't remember exactly how many domains are in the echo-wide protocol, echo-wide cohort protocol, but it's somewhere close to 200. So again, you can think of this echo-wide cohort as this tapestry of 70 individual cohorts woven together across with a data platform across many people, many layers of data, and many stages of the life course. The promise here is that with 50,000 plus children and their families, the ECHO investigators can address research questions that no single cohort or even a few can answer alone. This is a nationwide research collaboration, and it's meant to be a resource for the entire scientific community. And I'm going to talk a minute about solution-oriented research. So here we go. So a few years ago, Robinson and Savard defined solution-oriented research by the following. They said, do a research study only if you know what you will conclude from each possible result, and the result may change how you would intervene to address a clinical, policy, or public health problem. So we think of solution-oriented questions as so what questions whose answers lead to impact on child health through programs such as clinical trials, practices such as clinical practice guidelines, or policies that might be on the local, state, or national level. And what we're trying to do in ECHO is to see how these principles apply to observation as well as to intervention. Just one example from a recent paper published from one of the cohorts within ECHO. This is about trajectory analyses of body mass index. And the point here is that this kind of analysis may suggest potential sensitive windows for intervention. So on the left, you can see, let's see if I can find this. Here we go. On the left, you can see this is the BMI experience of kids who were exposed to different levels of parental obesity. So the top line is both parents obese, the bottom line is both parents non-obese, and the middle lines are one parent obese. And you can see that over here, these BMI trajectory curves start to diverge in infancy. So a simple implication might be, if you're interested in the implications of parental obesity on BMI in the kids, maybe interventions during infancy are the place to start to interrupt those cycles. On the other hand, on the right here, we have the experience, the BMI experience of kids whose mothers either smoked or did not smoke during pregnancy. Let me see if I can find this mouse again. Here we go. So this top line is the BMI trajectory of mothers who smoked during pregnancy. And the bottom two lines, pretty much congruent, are those who smoked either prior to or during pregnancy. And the difference is, here the curves diverge in early childhood rather than in infancy. So if you're dealing with the consequences of maternal smoking, maybe it's better to intervene at a slightly later time. Now, this is very simplistic because many of these exposures coexist. But this is just an idea about how trajectory analysis may be able to pinpoint the sensitive periods for intervention. So again, the promise of the ECHO-wide cohort is to address these questions that no single cohort can do alone. And so we've started this strategic planning process to identify the types of questions. What are ECHO cohort sweet spots? How to maximize value, one of our guiding principles. And pursue what we're calling a few big wins. So if you think about, what goes into deciding what questions to answer in a large consortium of cohorts like this, it might be the intersection of these three things. One is investigator passion. Clearly, that's true. The second is feasibility. So what does the protocol actually say we're collecting? So there's data availability, there's what we're interested in. But what about the end user decision making? So end users might be trialists, or it might be clinical practice guideline, or it might be policymakers. How do we involve those in making decisions about what to research? So I would say that investigators are really pretty good at these first two, but it's the end user decision making that needs more attention, and that's what we're trying to start in ECHO. We've just developed a strategic planning task force to try to tackle these issues. So again, the end users, trialists, public health programmers, guideline producers, policymakers, even cohort participants. We typically engage them when disseminating findings, if at all. And the idea here is the challenge is to do it up front to guide the selection of research questions. And this kind of stakeholder engagement, you might say, is similar to or analogous to community-based participatory research. Just in this case, the end users might be more than participants. Okay, let me turn for a moment to positive health. So if you think of health as a spectrum, health resources can be challenges or strengths. And if you look at this spectrum on the bottom, most of the time, the work that we do focuses on challenge. They might be disorders, they might be illnesses, they might be impairments. But if we look at the entire spectrum, we might also take into account strengths. So positive health focuses on strengths, not just on challenges. And it turns out that most of our instruments that we employ are much better at looking at challenges than they are at strengths. So I wanted to just report to you the results of a pilot study that some of our investigators did over the last couple of years in ECHO, which is to address the extent to which chronic illness is related to two domains of children's positive health outcomes. So those are global health and life satisfaction. So the question is, how do global health and life satisfaction associate with chronic illness? So this was a study of 5 ECHO cohorts who administered positive health scales to caregivers. So there were 1,360 caregivers representing 1,647 children, aged 5 to years with a mean of 7 years. Data harmonization, as you might expect, is a big challenge within ECHO. For this pilot study, they took sort of a least common denominator approach and just counted 0, 1. So if the child had a chronic illness, it was yes, and if not, no. So no distinction among chronic illnesses here. So if we sort of skip forward to the results, these are the results for global health. On the bottom line, you can see that the presence of chronic illness was associated with a diminution of 6.47 points in the global health scale. That scale has a standard deviation of 10, so this is about 2/3 of a standard deviation unit. You can also see some of the other predictors here, including race, ethnicity, and child stress, which you might expect to see with regard to global health. Now, in contrast, if we look at life satisfaction, you can see that chronic illness was associated with only a minus 0.3 diminution in that scale. Again, the standard deviation is 10, so it's really pretty close to the null. And again, you can see the associations of a number of other variables. So the conclusions of this pilot study are that among children, life satisfaction can exist in the presence of chronic illness. So even though global health scale is shown to be reduced in those with chronic illness, life satisfaction is not. So our challenge within ECHO is to identify and quantify the resilience factors for positive health in children with and without chronic illness. So it may be that if we can find the levers for life satisfaction, even in the face of chronic illness, we can do a lot of good for the kids. And I really like positive health because it's a child-centric outcome. A lot of our other outcomes we think of sort of way stations on the way to adult health, but this is really about what kids feel. And it tends to cut across our disease silos. So you can look at it in all of the other disease manifestations. All right, a few comments about precision prevention. So ECHO has a large diverse cohort and intervention network. And so I think we can think about precision prevention or precision public health across all of the echo domains. And so the things that I wanted to address right now are why do we care about mechanisms, the distinction between prediction and etiology, a note that with big data come big responsibilities, and an idea about computation as system science models that might help in tailoring interventions, especially prevention interventions. So why do we care about mechanisms? So I think as epidemiologists, we can say that synonyms for mechanisms might be pathways or explanations or mediators. And the best definition I ever heard for mechanism was by Tom Insel, who was the former director of the National Institute of Mental Health. He said that mechanism is one level of reductionism lower than you work in, which I thought was a great definition. And if we think about a simplified version of mechanism in developmental origins, we might have prenatal risk factors. Epigenetics, DNA methylation is one that people talk about a lot as a mediator. And we might be looking at a child health outcome like adiposity. So here we have an exposure, prenatal factors. We have an intermediate DNA methylation, also called a mechanism. And we have a health outcome called adiposity. So one thing that mechanisms allow us to do, because they're intermediates between the exposures and the outcomes, is see them as surrogate outcomes. So if we can see the DNA methylation actually is highly related to our adiposity outcomes, it becomes a surrogate outcome and makes studies more feasible. So we don't have to do the whole ABC, we can just do an AB. A lot of talk is about whether epigenetics, metabolomics, etc., can provide signatures for prediction. So I just wanted to remind ourselves of the two main purposes of observational research, etiology and prediction. So etiology is describing unbiased, perhaps causal relationships between exposures and outcomes, independent of other exposures. And that's where we invoke our conceptual models, directed acyclic graphs, DAGs, and our measures of effect are relative measures, or they might be difference measures. So relative risk is your sort of prototypical measure. On the other hand, in prediction, we're using values of all relevant variables to make predictions about individuals, we call those clinical prediction rules, or populations. So in those, we can use non-modifiable as well as modifiable determinants. And here, the most important outcome measure is risk, so absolute risk rather than relative risk. So when we think about whether these biomarkers can provide signatures for prediction, we have to keep in mind that now we're not talking about relative risk. We're talking about sensitivity, specificity. We're talking about area under the curve of a rock curve, that kind of thing. And the relative risks for single predictors that are needed to really separate populations when you're talking about absolute risk can be in the realm of hundreds or thousands. So we think of, in etiology of relative risks of 2 or 3 being very strong, but they're not very strong in terms of prediction. So we have to really remember that the bar for prediction is quite high. Also, these tend to be medical models. So oftentimes we talk about, we're going to find a predictor, usually a biomarker predictor, and then we're going to act on that mechanism. But usually what people talk about when they act on the mechanism is drugs. And it may be that we need to develop more drugs for pregnant women and children, but that might not be the first place we would look to improve the lives of children and adolescents. So in a lot of these new studies, there's the talk of big data. And of course, Echo will have loads of data. If you have many, many elements on 50,000 kids and their families, that's a lot of data to mine. But remember, with large sample sizes comes great power to detect smaller and smaller effects. And these effects may not be really important in terms of public health. And with great power, I think, comes great responsibility. We see the hegemony of p-values sometimes. We've seen that especially in omics, and we tend to neglect effect size sometimes. So I think we really need to bring our epidemiologic principles to big data when we're interested, especially in etiology. And remember, what is the solution-oriented question? When we're analyzing big data, is it just a shiny object, or what is our real purpose? So let's not forget quality in, quality out, sometimes called garbage in, garbage out. That we need to curate and harmonize our data. And again, prediction is not etiology. So if we come back to, why are we interested in mechanism? One reason we're interested in mechanism goes back to Bradford Hill. It's like, what's the biological plausibility for causation? And oftentimes, when we have an exposure and outcome association, if we find a mechanism that explains it, we're more sure that that exposure outcome association is real or causal. And so it's a rationale for primordial prevention. And by primordial prevention, we mean preventing the risk factors even before they appear. So when we're talking about in the obesity, diabetes space, cardiovascular space, optimizing the social behavior milieu starting at conception or before to avoid maternal obesity or excess weight gain or gestational diabetes or smoking in the first place, not primarily a medical model. So how might prediction actually inform primordial prevention? So I've said watch out for prediction, but maybe if we focus on combinations of potentially modifiable factors in our prediction models. So this is one study that, that I and a co-author published a few years ago, looking at 2 prenatal and 2 postnatal predictors of obesity, maternal smoking, gestational weight gain, breastfeeding duration, which I'm not sure has all the evidence behind it still, and daily sleep. And here you can see on the top line, if I can find my mouse again. Where is that mouse? Well, anyway, on the top line, if you had the optimal levels of all 4 of these risk factors, your mom didn't smoke, gained less weight, breastfed for at least 12 months, which is the Academy of Pediatrics recommendation, and you slept for at least 12 hours, the probability of obesity at age 7 to 10 years was 4%. Whereas if you had the adverse level of all of these, your mother smoked, gained more weight, you didn't breastfeed as long, and you weren't as good a sleeper, the probability of obesity was 28%. And this slide shows all 16 combinations of those 4 factors, dichotomized for simplicity. You can see the 4% on the left and the 28% on the right, and all the intermediate probabilities for the various combinations. So 4% to 28%, that's a fairly large difference. If you actually calculate a population attributable risk percent, depending on where you put your cut point, it suggests that by ameliorating these factors, you can save 20 to 50% of childhood obesity. But of course, the PAR percent calculation assumes both causality and modifiability. So that's only an initial calculation, and now what you have to do is do the interventions. So this kind of prediction model may suggest that multiple risk factor interventions in early developmental period hold promise for preventing obesity and its consequences. And of course, now you and many others are mounting such interventions to look at those implications. So in terms of prediction, if interventions might be multi-sector, maybe we can examine those in observational studies and can help to quantify the overall potential benefit of intervening early, and maybe distinguishing important determinants that may vary by population or subgroup. And these help to drive our intervention trials. Okay, so what about coming back to precision medicine for kids and public health? Really, as we've been saying, it's about prevention more than treatment. You know, a lot of the work about precision medicine right now has been invoking omics and other under-the-skin variables. But there's been a long history in public health of invoking above-the-skin variables, behavior and psychosocial factors that help us tailor interventions. So I think precision prevention in kids is really about tailoring interventions for subpopulations. And how might we do that in a new way that we haven't done before? So another study that I was involved in before I came to NIH was looking at computational system science models to tailor community-based interventions for preventing obesity. So this study is called Childhood Obesity Modeling for Prevention and Community Transformation, otherwise known as COMPACT. So it's trying to address the question of which interventions for which populations at which time. And, the typical question in precision medicine is which interventions for which person at which time. Here we substitute the word population for person. And it's about tailoring whole-of-community interventions to prevent obesity in early childhood. And so we developed, I'm not the agent-based modeler, agent-based models to estimate diffusion of two particular domains called knowledge and engagement through social networks within defined communities. And the way we did this was, first of all, we said, okay, in communities, there are likely to be different subcommunities, like childcare workers and like parents and like healthcare workers, each of which have a touch on children. Some might be more indirect, some might be more direct. They affect child decisions, child behavior, and child BMI. So we take that as our assumption. And then we say, well, we're less interested in this downstream where they're touching the kids. We're more interested in what's upstream, so intervention organization and what the intervention elements are. And then we say, well, based on some successful childhood obesity, whole of community childhood obesity interventions that have already taken place, it seems as though some kind of steering committee or task force or leadership committee is a key in driving the interventions. And those that steering committee is made up of delegates from each of these. I'm not very good with this mouse. Each of these subpopulations. So maybe there's one healthcare worker on the task force, and one parent, and one from childcare workers, and one from many other community organizations. And what happens in the steering committee is that it develops its knowledge and engagement through its interactions with each other. So it's developing an internal network within the steering committee. And then it diffuses, because they have representatives, it diffuses them, this knowledge and engagement, through these subpopulations within the community. And of course, the subpopulations are not completely distinguished from one another. They also have bridges between them. So the modeling assumptions are that the diffusion of this knowledge and engagement help make community ready to change and promote intervention success. And again, we can model the interventions featuring this steering committee with representatives from multiple community groups driving this diffusion process. And the summary of the preliminary results, I think, are interesting. They suggest that community conditions matter. So heterogeneity among communities can explain differential success, and here success is the increase in knowledge and engagement, even though the interventions are similar. So the initial community conditions of knowledge, engagement, and the structure of the social network are determinants of the success of the intervention. The organization and the activity of the steering committee matter too. So if there's a match between the intervention design and implementation and the community condition, that shapes how the diffusion actually becomes better than it would otherwise. So this model has been applied not only in silico to look at what happens when you have interventions that you can test within a model. It also matches what's happened in the successful community interventions to prevent obesity. And also, we use that model to create a new intervention in one of the communities, which seemed to have a lot of success. So anyway, this might be a new opportunity to tailor community-wide prevention interventions. It actually might be a new way of testing process. We often talk about testing process in interventions. Okay, so in summary of this part of my talk, precision public health for kids emphasizes primordial prevention over treatment. It's to guide what, how, and when. Intervention on selected mechanisms might be informative. We need judicious approaches to prediction and big data. And maybe this kind of computational modeling might help to tailor interventions. And ECHO offers opportunities both in its observation and its intervention sides for these kind of approaches. Lastly, just a few words on transdisciplinary team science. So one of the cross-cutting things we're trying to do in ECHO is to institute best practices for how to do team science in the 21st century. So we think of ECHO as a learning system where we learn, apply, and evaluate transdisciplinary team science principles and practices, and thus to improve program processes and outcomes in real time. As we believe with the right people and tools and a transdisciplinary approach that team science produces insights which result in the whole being more than the sum of the parts. And we try to do this by fostering a culture of collaboration, by listening and engagement. Team science in ECHO reflects, to the extent possible, the following principles. So a shared vision and guiding principles, I think you can see throughout this talk that we've been talking about that. Trust building is extremely important, as we know, in any team building exercise. Setting expectations. Communication, and by communication we mean multi-directional communication, not just out. Sharing credit and resources. We have to recognize that there are power structures, and we're developing processes through many of our policies that I think reflect these principles. ECHO is a cooperative agreement. That's a U mechanism, so it's between a grant and a contract. So NIH is a partner in a cooperative agreement. So our project scientists work on the working groups and have worked to develop the policies, etc. But what we really want is the investigators to drive the science, because that's where the great ideas come from. And we do that through working together through our various committees, steering committee and executive committee, protocol committees, a number of task forces, working groups, and I think we're well above 35 writing teams at this point. So finally, messages. Focus on the kids. We're trying to invoke solution-oriented research, where we're prioritizing evidence for impact on policy, programs, and practices, and starting to develop this work with end user stakeholders up front. I mentioned positive health, which cuts across disciplines. It's a child-centric kind of outcome, and it's a really new area of research. Precision prevention. Mechanisms can support etiology and thus primordial prevention. Big data, we have to be careful lest it be a shiny object. Tailoring interventions is not new, but ways to do it might be. And the best practices for transdisciplinary team science, I would say, are needed for large projects like ECHO, including those that use cooperative agreements as the mechanism. So thanks very much. This says, if they ask you anything you don't know, just say it's due to epigenetics. That's our mission. So I'd love to get into discussion. I know we have some time left. I did that on purpose. Any of these things or any other things that you want to talk about, I'm happy to.
Start with a question.
Right.
Thank you for the very nice talk. I'm curious how you view precision prevention within the paradigm of solution-oriented research, within all the work that goes into mechanisms and the theoretical work that goes into precision perception.
So I think, let's see, how can I address that most effectively? So the solution-oriented research, of course, is about finding ways that we really have an impact, right? That our evidence that we produce is having an impact to improve child health. There are going to be a lot of publications coming out of ECHO, whether it be the ECHO-wide cohort or whether it be the individual cohorts that are really interesting, that really dive deeply and can elucidate mechanisms, can increase knowledge. At the same time, I think we need to identify those where ECHO will say, this is where we really did improve child health. These are our big wins. This is what we can look back on and say, maybe they're 1 or 2 or 3 per year. And I think those can benefit from the knowledge of mechanism, as I was saying before, because mechanism is one way of helping to prove causality in observational studies. We never really prove causality in observational studies. But they can help us look at which of those exposures or which combinations of exposures we really want to intervene on. So I think the bottom line is there's room for lots of different kinds of research within ECHO. And today I was concentrating on the parts where I think we can move child health the most efficiently and most effectively. Does that tend to address your question? Okay. Yeah, Jed.
I like the analogy above and below the skin. I've never heard that before. I'm really interested in getting closer to more biomarker prediction. And so when we think about pregnancy, we know obesity, we know weight gain, we know smoking, and we know glucose, but we know very little below the skin. And I was wondering if you can comment on how you think this mechanism can help us get below the skin in terms of pregnancy.
Yeah. So you and I have talked about the kind of research you do, which is really interesting, about stem cells and how they differentiate and how they might, be in the face of certain exposures moving towards adipocytes rather than myocytes. And so you might say, well, maybe there's something in the stem cells we can measure, or maybe there's something peripheral that overlaps with stem cells that we can measure that's going to give us an idea about who's going to go which direction and who's not going to go which direction. I think it's important to try to do that. I do think that what I've done today is raise some caveats about the potential success of doing that. Because at the end of the day, what are we going to do with the information? If we really want to know that this kid is going to wind up differently from that kid, that's a pretty high bar of proof. So if we want to know that this kid is different from that kid, and we want to do something different for this kid than for that kid, that's a pretty high bar of proof.
I agree beyond birth, but I was going more backwards. Like we think now about transmission across generations.
Yeah.
You've got a lot of people talking about, what dad behavior was and what mom pre-pregnancy behavior is. Is that kind of built into this model? Are we going to see some more information about that? And then before you get a diagnosis or a change, you need to learn some new things, I think, in the beginning of pregnancy. I think the ECHO could help us do that.
Yeah. So even today I've heard about some work in the preconception period that a number of you are doing, which I think is fabulous, and I think it's a new frontier. Right now, ECHO doesn't have as much on preconception as it does on prenatal. On the other hand, you're also bringing up sort of intergenerational influences. And I think ECHO can help with that as well as many of the individual cohort studies within ECHO. I think at the same time that I put that in the realm of etiology and prevention rather than the realm of prediction, where prediction means really separating one person from another. And when I put that in the realm of etiology, I can also put it in the realm of precision public health, which is, can we identify subpopulations using both above and below skin factors that help us tailor interventions for subpopulations? But I think, you can marry those two, the intergenerational influences, etiology, and precision public health. Yes, please.
I was also I like this above the skin, below the skin idea. So I don't know if it's so different from Jed's question, but I was just kind of curious about more more thoughts on kind of like big picture ideas of how you do that or its role and like how do we integrate, like especially like in the realm of omics and like above the skin kind of things.
Yeah. Well, I think one way to think about this is system science, because below the skin, people have been talking about systems biology for a while. Oftentimes, systems biology gets to the point of, say, a network analysis, but it doesn't get to the next level of use of a network analysis, like in agent-based modeling or system dynamics or something like that. The example I showed you, of course, is using above-the-skin factors in a computational system science model. But I think if we could find ways to use those type of models for both the biology and for the above-the-skin factors, that might be really a good way of marrying them. Yeah.
So my interest really is the pregnancy diet, but I am very curious about the whole issue of breastfeeding, and you actually referred to that when you shared one of your papers. And so is there, or are there any of the ECHO cohorts looking at breast milk composition? Because, you know, the analogy I always use is fruit salad is good for you, but perhaps having one with berries and cherries may be much better than just having apples and bananas chopped up. And I wonder sometimes whether that is not why our studies on breastfeeding can sometimes be so disappointing when we look at the outcomes, because we don't actually focus on the composition for every mom and perhaps even every feed, and how that relates to the particular infant. So is that something you're looking at?
So I have two answers to that. One is yes, and one is no. The yes answer is I think there are actually 8 cohorts that have breast milk samples. And so there's the ability to look at breast milk composition. On the other hand, when you put together 70 cohorts into an echo-wide cohort, the depth of information about infant feeding is not going to be as great as it would be in individual cohorts. So I think in terms of the echo-wide cohort, you know, there'll be information about duration of breastfeeding, about complementary feeds, about formula feeding, but maybe not so much about the type of formula or the actual composition of the breast milk. That'll be more on the level of the individual cohorts. And I do think that, you know, when you put together a nationwide program like this, we have the advantage, actually, of looking at the big picture stuff in the echo-wide cohort and the depth that some of the individual cohorts go into some of these issues. So I think it's a good combination. Yeah.
First of all, again, wonderful talk. I thought it was very interesting. I was particularly fascinated with the way that you were describing the positive health measures and how they're, at least in my mind, I'm viewing it within the lens of resiliency and looking at psychosocial factors and how those may be a point of leverage to kind of move some of this. I was also interested in the study that you were talking about looking at the effect of chronic illness on both life satisfaction and then global health. I know that you just did a dichotomous measure of yes or no with chronic illness. Did you try any other ways of looking at that to see, for example, if these chronic illnesses or visible or invisible pain or non-pain associated, or mental health versus physical health kinds of things, and if there were any differences along that scale?
So there are analyses ongoing that are looking into much more detail of the positive health outcome. So nothing is ready for prime time yet. But I totally agree with you that some of the factors that we've used to predict disease, we can also use to predict positive health, especially in the psychosocial realm. And, you know, the comments you make are of course really interesting, especially maybe in relation to pain, because one of the other things, as you know, that's been really prevalent in this country and a priority of NIH is to end the opioid crisis as much as we can. And so ECHO, in both its observational work and its intervention work, is taking that on, mostly with regard to neonatal opioid withdrawal syndrome and maternal child sort of transmission of opioids. Yeah.
Thank you for your presentation. This is clearly like a massive project undertaking. I'm curious to know what are some important pieces of the conversation that had to happen to get investigators being willing to share their data.
Dick? I was just talking with Dick Hammond earlier because he was on our data sharing working group. And so I can give an answer. Oh, well, it should be Dick and probably Donna too, and because maybe I'll give an answer myself, and then those guys can chime in. So data sharing is clearly a big issue. All the cohorts came in existing. All the cohorts came in with experienced investigators who know their data very well. And so there are many reasons why investigators might be reluctant to share their data. Having been a cohort PI myself, I understand them. One is, I understand my data better than anyone. If I share them, somebody's going to mess up. Another one is, I collected these data and I get first dibs on them. Another one is, I'll share the data as much as NIH tells me to, but no more. So you might recognize those kind of responses. So in terms of rhetoric, I think the idea is to say up front how much value we can get out of sharing data into the echo-wide cohort because the whole is greater than the sum of the parts. And the kinds of questions that we can address with 50,000 versus 1 or 2 or 3,000 have much more import. Along the way, though, I think we need to pay attention to these kind of responses because they're legitimate responses. So, for example, we now have, I didn't put in the slide here, but we're thinking of data sharing in two levels. One is an ultimate anonymized public use data set, which we don't have yet. But first, an enclave, a restricted use enclave, in which the data go to our data analysis center, right? There are really strict security controls to get in, so that is about addressing privacy. But also that everyone who wants to do analysis has to go through the same processes of analysis proposals, which are looked at by a large group of the publication committee, so that everyone's playing in the same field. Secondly, very strong conflict of interest procedures, so that if there's a conflict of interest, only the data analysis center gets to analyze the data, not the investigator. Again, same playing field. At the same time, trying to address the fact that when there's a large consortium, responsibility and therefore the benefits can be diffused, and how can we support junior investigators to get as much benefit out of the echo-wide cohort as possible. So part of the answer to that is our Opportunities and Infrastructure Fund, which is meant specifically for junior investigators. So those are some thoughts along the way. So great idea, have some safeguards in effect so we can address these issues. Dick, do you want to say anything more about that?
That's good.
I want to complement that with something you told me in my office earlier today, which I like and I think it's very true. When you described your job as herding cats, oh no, herding lions. And maybe not herding lions, but putting in front of the
group of lions, several beautiful antelopes. I think that's the key.
Right, that's how I describe my job today.
Yeah.
Lions herd themselves better than anyone herds them.
Yeah, we'll go
And
for
the
it.
idea is throw a lot of antelope out there.
But I agree that making sure in this in today's academic environment where independence is highlighted, continues to be highlighted at a scale that may not be the most appropriate scale. We offer opportunities for people in junior faculty to collaborate and participate in the team science and not just projects that lead to independence.
And at the same time, we're really interested in evaluating how these things go. So our implementation teams always have the word evaluation at the end of them. So protocol implementation and evaluation, policy implementation and evaluation, because we want to be continuous improvers.
We have time for one more succinct question.
Succinct?
Yeah, you're good at that.
Thank you, Matt. We know here locally a lot about the cohort piece, but we're not as involved in the idea states. So I was hoping you could elaborate a bit on the trials that have started, maybe the ones that are in development, and how you see ECHO results directly informing new clinical trials, especially over the next few years as the ECHO protocol is just getting up and running.
Yeah, great question. So the idea states network is really different from the cohorts because it was established anew as part of ECHO. And there's a great range of experience in the idea states network between those who've had experience with clinical trials and those who haven't. So there's been a lot of capacity building within the network. The first trial that's in the field actually is a borrowed protocol from the Pediatric Trials Network of NICHD. It's called POPS, and I forget what POPS stands for, but it's evaluating pharmacokinetics of drugs that are routinely used in pediatric practice but not labeled for such use. And there's a list of, 35 drugs or something like that the network is interested in, many of them obesity related. So that has served as a great capacity building exercise because the network didn't have to develop the protocol. It took a protocol that was already developed, and the sites are learning so many things about IRBs and contracting and personnel and things like that in the service of something that actually could have quite a bit of benefit for kids. The second one is also a pilot study called Vidora, and that's also a pharmacokinetic study. The underlying issue is that vitamin D might be helpful in kids with asthma, but kids with obesity and asthma may need more vitamin D than kids without obesity who also have asthma. So it's a pharmacokinetic study about the distribution of vitamin D supplements in kids with both obesity and asthma. There are two on the drawing board. We hope getting close to the protocol review committee that are about opioid withdrawal in infants. And there's also just completed actually an observational study of neonatal opioid withdrawal syndrome, looking at the current practices and variation in care across the country of kids with that diagnosis through a medical record review. And then there are a couple of pilot studies that are on the drawing board. One of the differences between the cohorts and the Idea States Network is the cohorts are funded for 7 years, so we have about 4.5 years left for the cohorts. The Idea States Network is funded for 4 years. So getting things off the ground within that cycle is really important. Ultimately, the hope is that there's going to be crosstalk between the results of the Idea States Network and the cohorts. So that, you can imagine things that you find in clinical trials, you want to look at more closely in observational studies. Because clinical trials, you typically get, a single dose, a single duration, a single this or a single that. But it might raise questions in observational studies. And likewise, the ultimate goal is that things that the cohorts find in terms of exposure outcome associations could be tested in the clinical trials. Did that answer your question?
Yes.
Okay, thank you very
Thank you.
much.